Greetings, everyone. Welcome to the 249th session of the online Optom Learning Series OOLS. And for today's session, we have with us Dr. Rabia Mobeen. Dr. Rabia has received her MPhil in optometry degree and also a bachelor's of optometry from Lahore. And she has recently completed her PhD from the University of New South Wales. Her research areas involve studying the cornea, especially the corneal nerves and the corneal cells. And she also is working on creating a bioengineered cornea for corneal transplantation. And her research area also revolves around most of dry eyes, anterior eye, and cornea. And today, Dr. Rabia is going to share with us what are the effects of contact lens wear on the ocular immune response. So, welcome, Dr. Rabia, onto our platform. And I know we have a quick poll before we start. So, I'm just going to launch that poll and going to then leave the screen time to you. So, I'm just going to launch a poll for everybody to just put in their thoughts. I think almost 75% of the attendees think they are soft lens wearers are the more troublemakers, I would say,
Yeah.
rather compared to the corneal lens and scleral lens. So that's what the audience thinks. So welcome once again, Dr. Rabia, and I'm just going to leave the screen time to you now. Thank you.
Thank you so much. Thank you so much, Fakhruddin, and thank you for inviting me to this online learning series. I'm very excited to present today, like how contact lens wear affect the ocular immune response. What we are looking here is a confocal microscope image, but this is different from the other microscope because this is in vivo. In vivo means that we have examined this in living eyes. So we all know that cornea does not have any blood supply, but it has the highest nerve supply. Nerves here are 3 times more than any other body part. And what we are looking here is a pattern of corneal nerves where they enter like as inferior wall and then they spread into the cornea. These images have been taken from confocal microscopy and they have been stitched together as you can see here. Now, if we have a closer look among these nerves, we can see that there are some cells. These cells are the immune cells of the cornea or ocular surface, and these cells are present, as you can see here, with arrows and the circles. These are present in different shape and in different number. An average healthy cornea has almost 26 immune cells in the cornea. Now, we know that they are residing here and they can be present in different density and number. And when we want to see what is the immune response of the eye at that very time point, at any time point in the corneal ocular surface, what we examine about these cells? We image them with confocal microscope and we examine their density and morphology. By density, I mean the number of these cells. As we know, when we have infection in the body, the number of immune cells increase in our blood. So similarly here, when there is an infection in the eye, these cells increase in number. But when they are doing any immune activity or they are migrating, because I already mentioned that the cornea does not have any blood supply, when they have to migrate into the cornea or they have to move away from the cornea towards the lymph node, they change their shape. And when they are active, they can be present in inactive form, doing nothing, or they can be active when there is an immune activity or immune response or stimulus. So to study the immune response of the cornea or eye, we need to examine their density and morphology. By density, I literally mean that count these cells. And what I mean by morphology is that, as we can see here in these yellow dotted lines, that these cells can be present with different cell body size. They can be small like this, they can move to medium, or they can move to large cell bodies. So they have 3 types of cell bodies. And then these cells can be present without dendrites as they are present here, or if they are doing nothing, or if they want to do something, they develop the dendrites. Now, when we want to see what they are doing, we look at the shape of their dendrites. Like if the dendrites they are having, are they long or are they thick? So they can be present with long dendrites or thick dendrites. So by combination of this one cell body size and the shape of their dendrites, presence and shapes of dendrites, we can see what these cells are doing in the cornea or conjunctiva. I think this is very important. is a very good technique now with the help of the cornea. Is there any immune activation, suppression, or what is the immune status of the ocular surface with any stimulus? So to summarize the morphology, when these cells are doing their more immune activity, antigen capturing capacity, they have large cell bodies and they should have dendrites, and the dendrites should be long but thin. Thin, we say absence of thick dendrites. But when they are migrating, they move their dendrites inwards towards the cell body, and then they become short and thick dendrites, and then they have small cell bodies. So by looking at their shape of the cells, we know that what these cells are doing at that time point in the cornea. So this scaled morphology grading cells help us to examine the immune response in living eyes. Now we want to apply this immune response and their morphology grading scale and their density to examine the immune response of the cornea or the eye. So our first study, we aim to examine like what happens as soon as you put the soft contact lens on the eye. So this is important because we already know that soft contact lens wear is inflammatory. It activates the immune response of the eye in terms of tears inflammatory markers. There's a lot of literature that says that inflammatory markers increase in soft contact lens wearers. But we were interested in knowing like what happened to examine the immediate immune response as soon as you put contact lens on the eye at the whole ocular surface. By whole ocular surface, I mean their central cornea, peripheral cornea, limbus, and conjunctiva. And within 2 hours, like as soon as you put and remove the contact lens in 2 hours. So to examine this, like how the immune cells respond to immediate contact lens wear, we recruited 54 participants. And these participants were named, they do not have any exposure to contact lens wear, to any kind of allergy or anything. Their eyes were really quiet and there was no activity or something. So the mean age of participants were 27.6, and we had a wide age range from 8 to 44 years. We have kids and young adults as well. Why we were interested in kids as well? Because there is more complications in kids. So we recruited kids as well and adults, and 44% were female. So there was no sex discrimination like difference between the participants. And then we performed confocal microscopy in vivo in living eyes at baseline, and then we inserted soft contact lens 1 day UV moist for 2 hours. After 2 hours, we removed the contact lens and then we examined their density and morphology. By density, we counted these cells in the eye, and morphology, we assessed what are the shape of their cell body and the dendrites at central cornea, peripheral cornea, limbus, and conjunctiva. To examine a good area of cornea, we collected 5 images from each location. And then we counted the cells manually 1 by 1, and then we use a grading system to assess their morphology or their function. So let's see what happens as soon as you put contact lens on the eye. To examine this, let's examine some pictures. So this is the central cornea, and you can see there's a nerves and these are the cells. This is baseline, and the lower panel is the pictures after 2 hours. What I'm going to do here, I'm highlighting this one. As you can see, this fork of nerve or this bifurcation is the same nerve, and this is the same region. This is the same nerve that was examined at baseline and after 2 hours. And you can see here, these cells, where the cells were present, they are present, the cells got bigger and it has large cell body and long dendrites now. And it was not present here at baseline, but it was present in 2 hours. And cells, we can see similar, like there are more cells now after 2 hours. This is from the central cornea. Then from the center, we move towards periphery. And we observe that cells were not there at baseline, but they started moving in. And as you can see, in contrast to central cornea, the cells have short cell bodies and thick dendrites, and that's different from central cornea. And you can see the cells are moving in and they have retracted dendrites towards the cell body. They have become smaller. Then we move towards limbus, like what's happening at the limbus, and we observe that cells had thin dendrites or relatively thin dendrites at baseline, but then they have thick dendrites after contact lens wear in 2 hours, and they were literally small steps they were taking forward. They were moving forward. And then we move towards conjunctiva. Conjunctiva, where cells were absent at baseline, at the same region, cells were present after 2 hours of contact lens wear, but their morphology shape was different from that of the cornea. So then we applied our statistical analysis, like what these results say. And this box plot here is showing the density The yellow is showing at baseline and green is after contact lens wear. And you can see here at central cornea, there was minimal or no change in density. The cells were not increasing in number, not they were decreasing. But in the peripheral cornea, cells significantly increase in density. And when we move to the limbal cornea, there were similar results at the limbus cornea. But at the conjunctiva, the density number of cells were very lower, but still there was a significant increase in density. So except central cornea, we observed that cells start increasing in number. Maybe they were moving in from the lymph node or from the blood vessels, but they start increasing in number within 2 hours of soft contact lens wear. Now, as we were also interested in morphology, cell body size, again, the yellow bar chart here is showing at the baseline, and the green bars are showing after 2 hours. With different shades are showing the different grades of cell body size, and the darker shades are from the small cell bodies. What we observed at central cornea, the cells were getting bigger. As you can see, the shade of green, yellow is increasing, and we see that the cells were getting bigger at the central cornea. And similar results were observed at the peripheral cornea. But there was kind of different results at the limbal cornea, but this was not significant. And again, we did not find any changes in cell body size, the cell size at conjunctiva. So cells start increasing in their size at central and peripheral cornea only. And now, as we were also interested in knowing like what they are doing, what is their dendrite shape after 2 hours, we were also interested in long dendrites and thick dendrites. So we observed that the long dendrites increase significantly at central cornea, at peripheral cornea, but not at other regions. And then for the thick dendrites, we observed that this was most significant changes at the limbal cornea. And it was somehow also true for the peripheral cornea. So we observed that cells are getting bigger and having long dendrites, central and peripheral cornea, but they are getting smaller, not significant, but they develop thick dendrites at limbal cornea and peripheral cornea. So to summarize this, like what happens as soon as you put contact lens on the eye, I'm talking about soft contact lens, what happens is, this is a central cornea. We observe that the cell, they do not increase in number, but they increase their antigen capturing capacity. They increase in immune activity. Why I'm saying this is because I'm referring back to our morphology grading scale, where they show that the cells get bigger and long dendrites, so they have immune activity. So the cells get activated and they are activated for immune capacity. But when we move to the peripheral cornea, we observe that cells, they increase in number and they also get larger, and they also get long dendrites, thick dendrites, as we just seen in the table. So peripheral cornea showed all kinds of changes. The cells were increasing in density and they were getting more immune capacity, and they were also migrating. We don't know, like they might be migrating from the limbus towards the central cornea, but 2 hours might not be enough for them to reach to the central cornea. Then in the limbus, cells increase in density and they increase their migratory capacity. They might be moving in towards the central cornea. So here we find the cells start migrating, but in the cornea, we observe that cells start getting activated for antigen capturing. In the conjunctiva, we just observed that cell, they increase in density, but we did not find any difference in their function for immune activity or migration. This can be due to because our grading scale was originally designed for corneal cells, immune cells, and this was not designed for conjunctival cells. So it might just lack sensitivity to pick the differences in conjunctiva. So what we concluded from this study was that there is activation of immune response, that your immune cells get activated as soon as you put contact lens on the eye, which might indicate that epithelial immune cells play a critical role in contact lens-related inflammatory responses. So this was our take-home message from this study, that as soon as you put contact lens on the eye, there is immune activation throughout the cornea, but at the peripheral cornea and limbus, they get activated and they start migrating in. But when they reach the cornea, we don't know this because we did not follow up these participants after 2 hours. And at the conjunctiva, they just increase in number. So this was our immediate response of contact lens wear. Now we were also interested, like you must have this question, okay, if these cells get activated in 2 hours, so what's happening in the cornea of the people who are wearing contact lenses for many years? So to do this, we conducted a cross-sectional study. And then here, this is orthokeratology lens wear. What we are looking here is the nerve patterns in the people who have healthy cornea. This is the pattern. If you look at the confocal microscopy or nerve structure of people who do not have inflammation or any disease, their healthy nerves will look like this. But in our lab, we observed that people who are wearing orthokeratology lenses, their nerves have moved away from the cornea towards the periphery. And this is how the cells look like in orthokeratology lens wear. If you want to see confocal image, this is how a confocal microscope of a healthy cornea look like, and this is how it looked like in orthokeratology lens view. And you can clearly see the difference here. The cells are, the nerves are very less, and they are just a couple of nerves here that you can trace. But here you can see a beautiful network of nerves. Now, these are some experiments from a lab of Nangao, and what they say that these cells and nerves, they work together. They are interconnected. What they mean by interconnected is that if you remove the nerves from the cornea, these cells will also leave the cornea. And if you remove the cells and the nerves, they also fail to regenerate. So these cells and nerves work together. They are dependent on each other functionally. So if you see that there is changes in nerves, so there must be some accompanying changes in immune cells. So we were also interested in knowing this. So then again, we moved to another study. As I mentioned, like we were interested, like what is the status of immune cells in people who are wearing contact lenses for many years. I will not go into detail of this study, but I will just share the results. So this was a cross-sectional study in which we recruited 18 soft contact lens wear and 18 orthokeratology lens wears and 18 controls. And we observed that in soft contact lens wear, there is immune activation in which we observe higher density, larger cell bodies, and the immune response was activated. But in orthokeratology lens wear, we observed that in central cornea, these cells have leave the cornea, and if they are present, they're present with very small cell bodies, and they do not have any dendrites on it. This is how the cornea of soft contact lens wear look like, and this is of an orthokeratology lens wear. And we can see here in soft contact lens where you can see the cells are very big and there are many cells here, more than a normal person. And if you can see and they are very big and they have dendrites, they have large cell bodies. And if you go to orthokeratology lens where you can see the cells are very small, they're just like a dot shape. So they have lost their any activity or any function. So they are just present there at the mid periphery or at the cornea, but they're not doing anything. So we observed that the people who are wearing soft contact lens for many years, they have immune activation and cells have moved in. They are larger. They are larger in cell bodies. They have more dendrites, thick and long dendrites. And in people who are wearing orthokeratology lenses for many years, the cells have left the central cornea. But if they are there, they are present usually with very small cell body and without any dendrites. Now we wanted to know like okay, we know in soft contact lens where this is inflammatory response. We know that the inflammatory markers increase in soft contact lens wear. But what we were interesting here was that why is this happening in orthokeratology lens wear? What is the reason? So we thought our hypothesis was that it can be due to three reasons. Either it can be due to the lens material, it is different from soft contact lens wear, or this can be due to these people are wearing lenses in night, or this can be due to the mechanical pressure because these lenses apply pressure at the central cornea. And we also don't know like when these cells start leaving the cornea of orthokeratology lens wear. And if they have left the cornea, do they come back or they do not come back? So this leads to our second study, in which we aim to examine the effect of starting wearing and stop wearing orthokeratology lens wear on the density and morphology of corneal epithelial immune cells. We were just interested in looking at the cornea and not conjunctiva, and we wanted to investigate why is this happening in cornea of orthokeratology lens wear. Is this due to lens material, their fitting relationship, or mechanical pressure, or is this because these people wear lenses while they are sleeping? So how can we examine this one? So what our approach was that we fitted these people with rigid gas permeable lenses, RGP lenses. So these lenses were made of same material, and we asked this participant to wear lenses in night. So the only difference between orthokeratology lens wear and RGP lens wear was mechanical pressure. We thought that this should be due to the mechanical pressure of the lens, because we had another study in which we observed that due to the eyelid pressure, the cells leave in the superior quadrant and they move to the center. or to the periphery. So we hypothesize that this can be due to the mechanical pressure of orthokeratology lenses. To check this, we recruited 33 participants. The mean age was 28.2. These participants do not have any history of rigid gas permeable lenses or dry eye, but they did have history of soft contact lens wear. So this was a limitation of the study. So 16 people wore reverse geometry orthokeratology lenses for the same duration and made of same material, and 8 wore alignment fit RGB lenses. So they both are OK and RGB lenses both were wear for 3 months, and they had same material and same thing, but the only difference between two lens wear group was the pressure applied by the orthokeratology lenses. We requested RGB lens wearers to wear their lenses in night as well. So they both wore for overnight. But as you can see, we just had 8 participants because not many people agreed to wear lenses in night. And 9 participants acted as control. So we performed in vivo confocal microscopy at the central and mid-peripheral cornea. Why these two regions? Because here orthokeratology lens wear apply the pressure, and here the pressure applied by the lens is lower. So we picked two regions of interest. Then we performed our confocal microscopy at baseline when the people were not wearing contact lenses, and then after one month and 3 months of lens wear in both RGP, orthokeratology, and controls. But as we were also interested in knowing, like, if these cells have leave the cornea, do they come back to the cornea? So we examined this participant OK lens wear after 1 month and 3 months of stop wearing contact lenses. Then again, we examined the immune cell density. We counted them, and we used our morphology grading system to grade these cells. So let's move towards the results. So the density and morphology, our first thing was that, was this similar between 3 groups? Yes, the density and morphology was similar. There was no difference between density and morphology at baseline. So now what happened after 1 month and 3 months of contact lens wear? We are talking about the density, the number of these cells. So let's just talk about the mid-peripheral cornea first. So at mid-peripheral cornea, you can see, although there are some changes, these boxes here are presenting the controls, and these dots are from the RGB wear. Dotted lines present the OK wearers. And we can see, although there is some variation in density here, but we do not find any significant difference in density. And same after the cessation of lens wear, because there was no difference when these people start wearing orthokeratology lenses. So at mid-peripheral cornea, we did not find any changes in the immune cell density. But we had some interesting results from the central cornea. So again, these boxes here are presenting the controls. We did not find any changes in the immune cell density. In controls, in RGB wearers, although there was some increase in density, but this was not significant. But what happened in orthokeratology lenses, as soon as these people started wearing lenses, within 1 month, their density decreases significantly from the baseline. And after 3 months, there was no significant decrease, but after 3 months, it was significantly different from RGB lens wearer. So it means that they can be due to some mechanical pressure. And after 3 months, the density was significantly reduced than baseline. So what we observed here is that these people, the density has decreased significantly within 1 month. It might have occurred earlier, like maybe after 1 week or 1 day, but we only examined these participants at 1 month. And when we asked these participants to stop wearing contact lenses, we observed that immune cell density increases significantly. They started to recover when the lens, but cells density at baseline after 6 months was significantly reduced than baseline. So what this means, that the cornea did not achieve the status of normal healthy cornea, or the density was significantly reduced than the baseline. So the immune cells remained decreased, and they were, we did not find any difference in other two groups. So then we moved to our morphology grading scale. Again, these bars are showing here the different grades of cell body size, and the darker are showing the larger cell body. And interestingly, we did not find any difference in cell body size in any group and at any time point. So it means that we did not find any change in morphology for cell body size and for dendrites. Sorry for this busy slide, but this is showing the percentage of the shape of dendrites, presence of dendrites, long dendrites, and thick dendrites. And again, the take-home message here is we did not find any changes in morphology. This was little surprising for us because we did find changes in morphology in soft contact lens wear within 2 hours. So that was expected. Might be these changes had happened earlier and we were not able to detect them because we only examined these participants after 1 month of lens wear. So to summarize here, what's happening here? So we have already examined the nerve density that I have not shown today. So this was our previous study. We observed that in the same participants, when they start wearing orthokeratology lenses, there is a significant decrease in both immune cells and nerves within 1 month. And after 3 months, there is no reduction in immune cells, but nerves keep decreasing. So after 3 months, both immune cells and nerves they are significantly reduced from their baseline values. But when the lens stimulus is gone, they are not wearing orthokeratology lenses again. What we see that immune cells and nerves they started to recover, and they have almost recovered up to 80% in within 1 month. After 3 months, this was interesting. Like nerves have completely recovered, but the immune cells they start leaving the cornea again, and they were lower than baseline. So what this means is that orthokeratology lens wear might have disrupted the normal relationship between these immune cells and nerves because they were correlated, but at the recovery, they were not correlated. They were not showing the changes, similar changes. So it means that they have disrupted the normal relationship between immune cells and nerves. So now our answer to our hypothesis or our question, like why it is happening in orthokeratology lens wear. So when we compare the response to the similar material and worn similarly overnight, we only found the difference in the central cornea of orthokeratology lens wear. So we concluded that this can be due to the mechanical pressure because they are in the central treatment zone because the lens apply the pressure at the central cornea. So this can be the reason that we observed that these lenses are showing the immune suppression. And when this started happening in the cornea is that it was rapid. We observed our first time point was 1 month and the changes have already occurred. So it might have occurred earlier, but we did not examine these participants. So this onset is rapid. And do they recover fully? So the answer is no. When we examined this participant after 3 months of lens cessation, we still found that the immune cells density was not similar to baseline. So the cells remain lower than the baseline values. So the immune cell recovery remain incomplete. So now, what this study show us that we need to consider the long-term health of the cornea during contact lens wear. And our next question was that which corneas are more at risk? Are the corneas of the people who are wearing soft contact lens wear for many years, or the cornea of people who are wearing orthokeratology lens wear? In soft contact lens wear, we observed immune activation. In orthokeratology lens wear, we observed immune suppression. So which cornea are more at risk? Which is better? Is it better to have more cells or is it better to have lower cells? So we don't know yet, and this is our next study that we are conducting. But as we had a poll question in the start, and you said that the most people think 75% have seen more complication in soft contact lens wearers. So because these cells derive the immune response and they carry out all the immune activities, so it might be the corneas of people of soft contact lens wear are more at risk because there is immune activation, but we don't know yet, and the answer is still remains unknown. So we need to further investigate this, like implication or suppression or activation of immune cells. We need to understand what does the immune suppression and activation in corneas show us. So these are the results for today, like what happens to the immune cells of the cornea during contact lens wear. And with this, I would like to thank you all. I'm happy to take questions.
Thank you, Dr. Rabia, for sharing all that knowledge and information from the research what you and your group has been doing to understand. I think this has been the area of interest for quite many years, and we are still learning a lot in the recent years with the advancement in the technology on how to actually image the corneal nerves and look at the immune cells, and the evidence around this topic is building up. We clinically know that yes, all contact lenses do cause some kind
Some
of
kind of complications.
complications and response to the immune cells, but we, as you mentioned, we still don't know which type and which category or which modality of lenses cause more or less, so something which We need to
Yes.
understand. Yeah.
And it might be possible that because of this immune cell we have more severe responses, so we don't know which like we need to answer the know the answer of this question, like which like what complications are more severe and which corneas have more severe complications. And in rigid gas permeable lenses and sacral lenses we do not find any immune activation. So this is very
Yeah.
interesting to know, like which corneas are more at risk. And so for soft contact lens wear, orthokeratology lens wear, those who have immune activation or immune suppression, or those who do not have any change with immune cells. So yeah, this is very interesting, and we are still looking into the this area, like what we need to do with these cells and how, if their immune activation is a response, so how we can control them.
Yeah. One question which pops up is if you could just summarize or tell probably the clinicians, for research, we know that this is what is happening, but what is in for the clinicians in terms of when they are doing their preliminary examination or when they are doing their fitting assessment, is there some clue they should look at when they are evaluating the fit or doing their ocular health examination before fitting them with particular lenses? Do you have such evidence of clinician
Um,
related results? Yeah.
So now we have incorporated this in our practice here in UNSW. So all people who come for soft contact lens wear or dry eye treatment, we do check their baseline nerves and immune cells, and we found that these people, like who have some variation in them, they have different response to contact lenses. So I would definitely suggest for the practices who have confocal microscopy, if they can, then at baseline at least perform their check their nerves and immune cells, because this is not something that has been incorporated like in routine examination like on focal microscopy, but this is like I understand that this is little pricey, like we need to purchase tomo caps. Those people who are working on that, they might know this. But if you can, then examine their immune cells and nerves. But if you cannot, then make sure that their eye is like quiet and they do not have any other responses. And unless we establish something that can be done at every clinic, but for now, do not miss any test that they can do to examine that, and just examine that. But yeah, if they can, then I would suggest that to do at least baseline confocal microscopy to understand their nerves. And if they cannot, then we observe that most people show the signs of dry eye, so rule out dry eye very carefully. So we know that there is no any other thing or something dry eye, because these nerves are mostly associated with dry eye as well. So if you have any neuropathic signs or any dry eye signs, then be careful while fitting these people with contact lenses.
Yeah, yeah. I think that's important point, which I think every time we focus on is to you may not be able to do this confocal, but at least make sure the ocular health, as you mentioned, make sure dry eye evaluation is done properly, and looking at the cornea, looking at the ocular health in itself. So it's really important to, as a clinician, you can just start from there if nothing else, right? Yeah.
Yeah.
Okay. There's one question which I think came up on the chat. Probably you have covered it up also during your presentation, but if you would like to just summarize here that do you think the changes would be less in scleral versus RGP to ortho case? So any concluding thoughts you would like to
Um,
put in here?
Yes, I have not presented the data today because I thought would be too much. But in scleral lenses and in RGP, we did not find any change in immune response, and we do not know why. Because maybe their material do not have much interaction with the eye or something. But we did not find any changes with scleral lenses and with RGP lenses. We just observed the changes with like we observed that immune cells show some changes with orthokeratology and soft lenses, but not with scleral lenses and not with RGP lenses. And we are still working to know why is this like this the case with the scleral and RGP and orthokeratology and soft lenses. But yes, if you ask me for scleral lenses, there is no change in immune cells nor in their density or their morphology with scleral or with RGP lenses. So yes, it's not less, there is no change.
There's no change. Okay, great. And
Mhm.
what type of contact lenses then I think is connected to the answer again. Any type of contact lens wear can reduce the relationship between the cells and the nerves We do
Mm.
not want to disturb the nerves, of course. So is there any type of lens which will not do that,
So
perhaps?
soft contact lenses, no, no, all three types, RGP, scleral, and nerves, they are not disturbing the normal relationship between immune cells and nerves, but orthokeratology are just disrupting their normal relationship. So do you think it's better not to disturb? Obviously, you don't want your normal and healthy things to get disturbed. So obviously, you will like to have all these baseline values. You will not like to have reduced density of nerves or immune cells because it will be, we think that will be difficult to pick up any problem or any inflammation or other things in the eye. So we have not just tested this yet, but I think it will be more dangerous to have less cells or nerves in the eye than to have more cells. So yes, it's better not to disturb. Of course, it's better not to disturb that normal relationship, to have them in a healthy range, both immune cells and nerves, their density, their morphology, and their relationship, because they work together. So if you disrupt their normal relationship, they will not be able to work together, and I think the ocular homeostasis will be disturbed. So yes, we will not like to the relationship between immune cells and nerves to get disturbed, and we would like to resolve this with all type of contact lens wear.
And is there any role of oxygen permeability of the material, in terms of higher decay material versus low decay material? Have you tested on these kind of things? Do you find any changes when it comes to decay value?
We have not directly done this, but there is some studies by and one of our colleagues. She has done this in US, and they have observed that there is no change within soft contact lens wear of different materials of different decay values. So no, decay values does not disturb. They observe immune activation in both type of decay values. So there was no difference between different decay values contact lenses, but they did find that different solutions, contact lens solutions, they have different effect of on immune cells. I don't remember exactly which brand was that have immune activation, but yes, contact lens solutions do have different response on different effect on immune cells, but not decay is not it's not affected by decay values of cells of lenses.
Right. And I think you mentioned about the corneal lenses did not really show much of changes or did not show changes at all. Could it be because of the diameter of the lens? Because there is a limbal vasculature, the region is uncovered, and due to that, physiologically, the lens are better. Do you think that could be one of the possible
Yes.
reasons? Yeah.
We think that because cornea does not have any blood supply and all the limbal vessels are residing in the limbal area, so we think that the cells might be coming from limbus towards the central cornea, and that's the area when it's irritated, it initiates all the response and the cells start getting in. And as I mentioned in the 2 hours contact lens study, that most of the changes happen at the peripheral cornea. So we think that because when the periphery is not irritated or activated, the central cornea might be reserved. So yeah, we think that in scleral or RGP lenses, the diameter can be a primary reason, because these cells or these lenses are not doing anything to the periphery. So yes, this is one of our hypotheses for our next study, that we're trying to understand, like if limbus and periphery cornea is not disturbed, how this preserve the central from getting activated.
And we'll take one more last question. I think the research which you presented was about the 2 hours effect, which was definitely seen as after 2 hours we see a real change. Do you think there is a need of a minimum wear schedule now? Because already in 2 hours we see a change. So do you think that can be something which can be studied on different type of lens designs or materials or types? We have a minimum time or wearing schedule to be recommended to our patients, perhaps.
Yeah, this is a very good question, but I don't think I have a definite answer to that, because we did examine the corneas of people who are wearing contact lenses for many years, but we did not find anything like unusual, because these people were wearing contact lenses for many years, but and they have immune activation, but we did not find any complications. So we don't know. This might be an adaptation response of eye towards the contact lens wear. So yes, we need to look at new minimum wear schedule, but we don't know like what is the minimum wear and the there's so many things we don't know yet. So I cannot say something definite about this answer, but yes, this is something that we can look into the future. Yeah.
Yeah. And just one question popped in terms of ocular surface, what is the role of the microbe which helps to modulate, yeah, the
Mm.
immune response? Is there any role, and how can we go about evaluating or monitoring that?
Yes, so we are monitoring this. So from the people from the 2 hours contact lens studies, we have collected the samples and we have collected their tears as well. So we are analyzing like what are the changes that are occurring in the tear inflammatory markers and neuromediators and the microbiome of these cells. So we will have this answer. Yes, microbiome, and we did observe that the IL-17 was changed significantly with immune cells, but we don't know about microbiome yet. This is something that we are looking further into it, and yes, we will mention this like in the next talk. But I don't know, like in the minimum time in 2 hours, what is the changes? What are the changes in the microbiome? Microbiome, yes, but we expect there should be some changes in microbiome and in the T-inflammatory markers of the eye.
Okay, great. So I think with that, we have taken most of the questions. There are a couple of them which have popped up. Should I just take one more, Dr. Rabia? I'm just going to take one more. Sorry, this is
Yes,
just
so
coming up.
I can see one question from Asad. Like, what
Yeah,
steps can contact lens wear take to minimize immune-related complications?
yeah,
Okay, that's a very good question, but we don't know how we can control these immune cells yet because this is very new field, and we know that immune cells are getting activated. So, for many years, we think that the cornea is immune privileged. It does not have any immune cells of its own, and the central cornea is devoid of blood vessels and immune cells because of its clarity. These cells have been recently like diagnosed, and from the last decade, there is a lot of work on these immune cells. So we don't know yet. So we don't know like what this they can do because we are still understanding these cells. So we need to explore them more, as you mentioned. Like we need to explore their microbiome, their relationship with nerves, their T-inflammatory markers, the pathway associated with this immune activation. So we are still exploring that, and there will be some translation of this study into the clinical work, but we still don't know like what they can do because we are still understanding that. So like maybe in 5-10 years we will know that how this we can control these cells, but now we don't know. Yeah, but till now, then like the normal contact lens care, I think we should emphasize on that.
yeah. And is there any role of physical or chemical properties of lens material that has on the immune response?
Physical and chemical properties of contact lens wear. Biophysical and contact lens material. We have not studied yet, and chemical properties. I think no, but we don't have any evidence for that. But we did not study this yet. Yes, we will do this in future, but for now, we have not conducted this study. Yeah. And we don't
Yeah,
know like how chemical properties and physical properties. Yes, we can change the parameters and see, but we have not done this yet.
wonderful. Right.
And there's
And
one more
one,
question.
yeah,
Sorry. Yeah. What about the systemic conditions of the people in your study? Like they are prone to any previous allergy responses, especially ortho K. Like they prone to any previous allergy responses, especially ortho K. So these all people, they were free of any systemic conditions or any other ocular problem or any other systemic problem. So and no, and these people, like the people who we recruited, they did not report any adverse event or any other problem with their health during the study period. So no, so these people were really prone to any other disease or any other condition, ocular condition or systemic conditions. We do not have any problem with these people, and they did not also report any adverse event during the study period.
yeah. Yeah. So I think a lot of things are yet to discover. We are just trying to understand, that there is a difference, but we still don't know what are the influential factors other than, the contact lens care materials, which we have a clear evidence. in terms of influencing the immune response. We know ortho care has some effect. We are still understanding a lot in terms of mechanism of other lens materials, the physical, the chemical properties. But I think what we need to kind of get a message is perhaps to look carefully and deeply for our patients to kind of let them understand and minimize the risk of potential vision threatening complications if we are able to do it at an early stage in clinical evaluation. So I think that should be the key for learning for today, right? Yeah.
Yeah, I think the things that we are doing now, we need to keep doing them unless we have some like clear evidence of something that can be helpful in the clinicals. Yeah, so we are still working on this understanding these cells and immune responses. So we will have more answers to your questions in future. So for now, we just know that there's immune activation with soft contact lenses and suppression in orthokeratology, and no immune change with RGP and scleral lenses.
Wonderful. Great. So thank you once again, Dr. Abia, for sharing all that information and also some thought-provoking research questions, I would say, did come up during our discussion. So thank you so much for sharing and spending your early morning with us today.
Yeah, thank you so much for inviting me. I'm looking forward to more questions and talks in future. Thank you so much.
Sure. Thank you. We do have session planned over a few weeks' time. Yeah, until then, take care, be safe, and I hope to see you during the next session. Thank you and bye bye.
Mhm. Thank
Bye.
you.
Thank you, Dr.
Okay,
Bye.
I'll see you soon. Okay, bye.